To today's webinar brought to you by the Orthopaedic Research and Education Foundation India. This is through OrthoTV, and today we have the pleasure of having Dr. Swarnendu Samanta from Calcutta, from Peerless Hospital, Calcutta, who's going to talk to us about the examination of the foot and ankle. So, Swarnendu, without further ado, it's over to you, and you can get started with your talk.
Thank you. It's a real honor and pleasure to meet you again, and that too with John sir and my dear friend Dr. Janki and all my colleagues, my friends and the juniors, those who are listening to. Today we are going to discuss the how to examine the foot and ankle, that too in a very stepwise manner. When we discuss like your shoulder or the knee or any other joint, we go in a stepwise pattern. You know that there is a set protocol of examining any joint. Like
you have to go on full screen.
It is already full screen in my side.
No, not on the.
Okay, just 1 second.
This also close. Now share. Share your screen. Now select the presentation.
Is it coming?
Yes, now it's fine.
Okay. So there is a set protocol for the foot and ankle too. Like the shoulder or the knee, we have to be very vigilant about the history taking. You have to listen to what the patient is going to complain. That history will guide you to many of the things, and you will be diagnosing the things, or it will lead to your diagnosis. Then the thing is that we have to go like look, feel, move, then special test and few measurement. We have to look into the real anatomy of the foot, because we know that the foot is composed of 26 bones and 33 joints and nearly 100 of ligaments. And every day, suppose we take thousands of steps, then you can understand how many steps or how many miles or kilometers a person is going to take load on both the feet. And also you have to read the anatomy, not only the bony part, you have to understand the anatomy of the extrinsics and the intrinsic muscles, the tendons, the ligaments, where the main artery, vein and nerves are there, and the ligaments, how they are attached to their origin and insertion, because otherwise you won't be able to understand the critical test and you won't be able to diagnose. So basically, this is the foot model that we are seeing. Then once you take the foot model, then you will be understanding that how the bones are oriented. Then you have to understand the anatomy of the medial side of the ligament, how the deltoid, what are the components of the deltoid ligament, what are the components of the lateral ligament, and how the tibiotalar joint is formed, how the capsular attachments are there. Because you know the tibiotalar joint is a saddle joint, the plantar flexion and dorsiflexion, which happens in the tibiotalar joint. And the other movements like your inversion, eversion, that is a composite of movement. Mostly it happens in the subtalar joint, or also some movement is also there in the talonavicular joint also, and in the mid-tarsal joints is there. Also there is adduction and abduction movement is happening. And if you read the arches of the foot, it is not only the one arch that is on the medial side. There are two arches. One is on the medial side and one is on the lateral side. These are the two longitudinal arches. And also there are two transverse arches like this picture is showing, one in the proximal in the cuneiform region and one in the, this is the metatarsal arch. And you have to understand how the plantar fascia is attached to on the lower part of the foot. So this is known as the windlass mechanism. The windlass mechanism, if you understand, then you will be able to understand how the flat foot happens and how it takes the rigidity or the flexibility of the flat foot. And now, if before we go into the detail of examination, we have to understand how the foot is being given the sensation, because you have to understand where is the supply of the medial plantar nerve, how the lateral plantar is supplying the fast waist space. You all know this is the area for your deep peroneal nerve, and this is the superficial peroneal branch, how is supplying, and this is the medial side, how it is supplying on the medial side. So this is the saphenous. This is the yellow area is the saphenous area. So you have to understand both on the sole side and also on the dorsal side, also on the back side. This is the area of the sural nerve sensation area. So you have to understand the distribution of the nerves, how it is supplied, because foot is very, very sensitive area. Then you have to understand how the dorsiflexion and plantar flexion, as I already told you. Then the dorsiflexion is around 20 degree and the plantar flexion is around 40 to 50 degree. Then how the foot inverts and how the foot everts. Because inversion movement, when we do it, basically it is a combination of three movements. If you do yourself, you will be understanding that when we invert the foot, basically there is dorsiflexor, there is adduction, and all the adduction is also there. So then it inverts, and it is the inversion movement. And when we invert the foot, basically it goes in inversion. It is going inwards, and when it dorsiflex and go outward, that is the eversion movement. And when we examine any foot patient or the ankle patient, always remember that we have to see how the patient is entering into the room. You have to see the foot or the ankle, and you have to properly expose that area up to the mid-thigh level with the permission of the patient. Then otherwise you won't be able to see suppose there is some quadricep wasting or there is a calf wasting. If you just examine the foot part, they will be missing something in the thigh region or the calf region. So the proper exposure, like the other joints, it has to be properly exposed with the permission of the patient, so that up to the mid-thigh level is exposed. And the thing is that you have to ask the patient to walk so that you can see from the front and then go back again, so that you can see how the patient is walking from the back side. And also you have to see from the side how the architecture of the foot. The gait is also very important. And so the static gait, that suppose the patient is standing on both the feet, then you have to look from the front, from the side, from the back side, like this way. We are seeing from the back side. You see in a normal foot, there is 5 to 6 degree of valgus of the heel. And then you can see how the tendoachilles is going, whether there is any scar, whether there is any fullness by the side of the tendoachilles, that we have to see. Then how many toes are being seen when the patient is standing from the backside. Usually we see around the little toe or the fourth toe from the backside. And then you can ask the patient to stand on the tip toes, so that you can see how the heel is going, whether the heel is going into, how the heel is going into the varus, yes or no. So these all you have to see during when the patient is walking towards you and going back. And also you have to examine the foot, looking for the foot from the front, from the side, from the back. And then when you see this picture is very important for us, because what is the difference? What are the different things that we can look in the toes? One is the mallet toe, one is the hammer toe, and one is the claw toe. In the uppermost picture, you see the mallet toe, like your mallet finger. the joint, the metatarsophallangel joint here, and the PIP joint is normal. Only the DIP is flexed, like your mallet finger. What happens in the hand? But in the hammer toe, if you see the hammer toe, this goes like this, and also there is hyperextension of the DIP joint. So what is the difference between the hammer toe and the claw toe? You see, there is hyperextension of the distal interphalangeal joint, but in a claw toe, though there is flexion of the PIP, this distal interphalangeal joints also will go into the or also the flexor. So this is the difference between the hammer toe and the claw toe. So when we take the history very carefully, we like the other joints, you have to take the age, occupation, whether this patient is a sports guy, what sort of sports, and what is the job he is doing to. Then the no foot examination is complete until you examine the spine, hip, and the neurological examination, and also the knee, because some deformity in the spine or the hip or the knee can go to the foot, that can create problem in the foot. So this part, the examining the spine, hip, knee, and the neuro is very important. Also the medical history, like whether the patient is diabetic, whether there is any neuropathic problem, the peripheral vascular disease, any arthropathy, or the multi joint involvement is there. Also the vasculitis. These are all very important history in categorically we take to. Then you see this is the tenile sign. So when you test on the so this is the way how you test the tenile sign, like your median nerve, you test like this. So in inspection also, whether there is a trauma or this is the traumatic problem, then that you have to take. So in the trauma, you have to say whether where is the swelling, whether the patient was able to walk after the injury, yes or no. They have to see whether there is any ecchymosis and the alignment of the foot. Always remember that whenever there you see from the sole side, there is ecchymosis on the sole, be very, very vigilant, because the Lisfranc injury is a very commonly missed injury. Whenever there is ecchymosis on the sole side, never miss the Lisfranc injury. You have to test critically, and also you have to take a weight-bearing X-ray. Otherwise, you may miss the Lisfranc injury. So the ecchymosis on the sole is a very, very important sign. Also, ecchymosis around the, you see in the first left picture, around the heel, this will dictate, it will tell you that something is happening on the lateral ligament complex or the lateral malleolus or your calcaneus. Also the history, suppose somebody has fallen from the height or a ladder, that will tell you. Suppose somebody has in a scooter is going and there the foot hits on the bump, then you can know that this can be, the history can tell you where that it can be injury to the Lisfranc injury. Now the inspection, as I told you, when the also from the back side, also from the side.
This.
Now you see the leg is just how it is propagating. The leg is propagating in a manner that is 10 to 15 degree external rotated. Then these things you have to understand what is the pes planus and what is the pes cavus. In the pes cavus, there is basically a planovalgus foot, and there is you see the completely arch is gone, then how the heel has been gone into the varus. And when there is a pes cavus deformity, you see the arch is high arch, and also the heel goes into the varus. And this is a pes cavus deformity. So the anterior draw test, now we are coming one by one, in your clinical examination, in the masters or in the DNV examination, some the examiners will ask you to show some of the few clinical tests which are very important during the practical examination, like your anterior drawer test. The anterior drawer test, basically, like how you do in the knee for the ACL, it is like that. Whenever there is, suppose there is a ATFL, the anterior ATFL injury is there, then the talus, suppose this is the anterior ATFL here, then the talus will come in front. See how I am holding the heel. You see the movement, how much is coming in front. You see how much the talus is going to help. This abnormally moving in comparison to the normal side, more than 5 years, but you know that there is starting from this quality. So always remember that you have to taste from the normal side, then only you will be able to understand. This test is very, very important. You have to understand what is the importance of the Kolkata. I will stop. I will again come to it. This is test for the cave of varus foot. Basically, with the block here, this block we are giving on the lateral side of the foot, and we are allowing the fast ray to plantar flex. If the fast play is plantar flexing and the heel, which is in varus, is being corrected, then you know that this component is from the forefoot. But if it is not corrected, after giving the 1-inch block on the lateral side, then you know that there is also the hind foot component is there. So by giving the block on the lateral side, like on the 4th and 5th toe, if you allow the fast ray to plantar flex, then if the heel varus is not corrected, then it is a rigid one, and then your subtalar joint is also involved. If it is the corrected, it is going into neutral and valgus, then you know that this component of the cavus or the cavovarus, the component is coming from the forefoot. So you have to, this test will, the Coleman block test, we will tell you whether this cavus deformity and the varus, heel varus, is coming from the forefoot or the subtalar component. So this will distinguish between the forefoot and the subtalar component. This is the, now you see, this is the heel rest, what we do for the tibialis posterior tendon insufficiency. We know that is known as the adult acquired flat foot. When you do that, then whether this can be done even with a single leg. Can see the residual component in part sensor on the longest in the toes, and you can see in the feet on the plantar and dorsal surface whether they will be feeling or present is already out there. For the emergency surface not being low. Another one is the squeeze test, which is basically squeezing on the address and ask whether there is any in this way. So this is the modulus Quick's test, that so you can feel the motor neuroma, which happens mostly in between the 3rd and the 4th metatarsal, when you palpate with your thumb and the index finger in the wave space, so that you can feel that, and patient will complain of pain. You can feel the nodule there, and also you can do the metatarsal compression, the modular test. By this compression technique, also patient will be feeling that it is painful. This test is very, very important. That I can stop here for some time. That before I go into the video of this test, I will request that listen to it carefully. That the silver squill test, that you have to understand that whenever there is a equinus deformity or there is a contracture of the gastrosoleus, you have this test is to identify whether the gastroc is involved in this contraction, yes or no. We all know that the gastrosoleus, the origin starts from the posterior condyles of the femur. So it crosses the knee joint. So now if we dorsiflex the ankle, like you see the how my foot is, how the patient foot is resting on my forearm, how I am holding the ankle joint, I am dorsiflexing the ankle. Now you see, once in the extended position, I am going into flexion. That means I am flexing, that means I am relaxing the gastrosoleus. So if there is increase of your dorsiflexion in flexion of the knee, then you know that your gastroc is involved in your contracture. So from extension to flexion you go, then you will be understanding. Now you see, now probably you have understood what I am. So only thing you have to remember that as the gastroc is crossing the knee from the extension to flexion, if you are coming, if your gastroc is involved, that means involved yes or no. So if your dorsiflexion is increasing, that means your gastroc is involved. So when you flex it, if there is increase in dorsiflexion, there is involvement of the gastroc. So I think you have understood this silver scale test. So this will be like. Then you have to test this is the squeeze test for the syndesmosis. From the upside, with both you see how the foot is and knee is bent, and it skews from the proximal side, so that you understand and you ask the patient whether there is any pain and the syndesmosis. This is a squeeze test for the syndesmosis. Then this test you have to understand the talar heel test, as I told you, the anterior drawer test. This talar heel test can be done in 3 positions. One is the dorsiflexion, one is the neutral flexion, and one is the plantar flexion. When you dorsiflex and you tilt the talus, then you test the ATFL. Then when you do this in neutral flexion, then you test the CFL. When you plantar flex and you do the talar test, same thing, then you test the PTFL. So this talar test can be done in 3 ways, like in dorsiflexion, neutral flexion, and the plantar flexion, to test one by one the ATFL, the CFL, the calcaneofibular ligament, and the PF, posterior talofibular ligament. So this is the way that you have to see, and always remember that you have to compare this thing with the normal side. First you explain this like the other joints, you do it normal side, then you do on the other side, so that you know whether there is any insufficiency of the ATFL or the CFL or the PTFL. This is also the case for the syndesmosis. One is the dorsiflex, and then you externally rotate it like this. So then you may rely on even during the when you fix the ankle, during in the C-arm also you do the external rotation to see whether this syndesmosis is opening, because you see the talus will try to, when you do dorsiflex and externally rotate, the talus will put the impact on your distal tibiofibular joint. So you can, if there is opening of if there is any tenderness, a patient is complaining of pain, then you will know that there is a syndesmotic injury or there is a problem of the distal tibiofibular joint, syndesmotic injury. This is the talar heel test, as I told you. like this. They like this when you have to see the another screen okay. So they normally again you have to compare the normal side. They see how much is opening on the lateral side. So it is in lateral vessel, you basically is the medium and you use you place the talus, then the continuous urine. And when you cross it and do the same thing that you place the medium. I think this is the easiest test to remember for this thing. If you see, the patient is prone, and if you squeeze it, this is for the integrity of the tendo Achilles. Also, you can see whether there is any gap or there is any tenderness in the tendo Achilles. So this is this Thompson test to check the integrity of the tendo Achilles. So when you can ask the patient to walk tiptoe, and also you will ask the patient to walk on the heel so that you can check the dorsiflexors. So this is the too many sign. Whenever there is the you see, normally you will be, as I told you in the beginning, normally you will be seeing the fifth and the part of the fourth toe from the backside. But if the heel goes into the varus, then there will be too many toes, more than 3 toes, or the 3 toes will be seen from the backside. So this is known as the too many toes sign. This is the too many toes sign that you see from the backside. It will be more than, it is like 3 to more than fourth and fifth. If you see the third toe from the backside, then you know that this is the too many toes sign. Another one is the calf toe. So this is now the forefinger. So you have to stabilize the head of the very fast red cluster. Then you have to go with the extensor. Then you like this. Then if it is going beyond so this is for the calf toe, means that is a polar plate injury that we can understand by this test. This is done by the 4 fingers, like pushing into forced dorsiflexor, so that you can understand that there is an injury to the polar plate. And also this is the dorsoplantar dyad test, as you can do. This is like your calf toe injury or the polar plate injury. This is the pictorial diagram, what we do to understand the calf toe. This is these days some examiner, they will ask you how to classically know, because as I told you, the inversion is a very complex movement. If you to understand the classic inversion at the subtalar joint, you have to lock the talus and the navicular. So now you see that my right hand is holding the neck of the talus and the navicular. So you see, and then you test it, then only you will be able to, then you just evert and invert your joint, then only you will be understanding the actual classic movement of the inversion. So basically with the hand, you have to, the right hand, suppose I am examining on the right hand, I will lock the neck of the talus and the navicular. Then with the left hand, I will hold the calcaneum like the cup, and then I will evert and invert. Then only I will be eliciting the inversion and reversion of the subtalar joint. So this is the picture from the different textbooks. This you have to understand, because in the exam we will be getting these cases. You have to understand the theory of the CTEV, the congenital talipes equinovarus. You will be sometimes getting this hallux valgus with the bunion and with the hammer toe. Then you can get this deformity in the middle of the picture, that is the metatarsal adductors. and also you can get the calcaneus. These are all very theoretical things that you have to read from the textbooks, but the classically you have to follow like the other joint, look, feel, move, and then you do the special test. Some measurements are there. The measurements are mostly for the wasting, either whether there is any wasting in the thigh muscles or the calf muscles, or else you can measure if there is a small foot unilateral deformity, then you can measure the medial side of the foot and the lateral side of the foot, and you compare with the normal side, so that you understand there is a small foot that you have to take care. So now no foot examination is complete if you don't examine the footwear. So if you examine the footwear, and you can do that at the beginning of the examination or else at the end of it. Mostly you can do at the beginning when they take off the shoe. Then suppose there is the footwear, when there is the cavus deformity, suppose there is a cavus deformity, the patient, there will be more wear on the outside, on the outer side of your footwear. When there is a planovalgus foot, the patient is walking on the medial side, so there will be wear on the inner side. When there is a equinus deformity of the foot, the heel will be okay, but there will be, if you see the inner side or the outer side of the toe side, you will be see the wear. So you have to, normally when we as our heel is 5 to 6 degree of valgus, usually the wear pattern is mild on the medial side. But if the reverse happens, then you know that this is a heel varus problem. So the stepwise pattern of doing the ankle and foot is like your look, feel, move, and then you do the special test, and the only few measurements that you do for the wasting and the foot by the medial and the lateral side, so that you can compare with the other side. And also remember that whenever you examine the foot, that you have to examine the patient walking, standing, and you have to see from the front, from the back side, and from the side. Then only your foot examination is complete. The inspection part, the palpation, as you do, like you have to palpate the bony points, and always ask the patient to tell with the index finger where he is facing the maximum problem, because that will guide you to the pathology. And by inspection and the palpation, you always never forget to palpate the pulses, because that is also very important. Your neurological examination, the Hagland deformity that you remember, then the plantar fascia, that it is on the never in the middle of it. The heel pad atrophy is at the middle of the heel. The plantar fascia classic one is on the medial side of it. So these things that you have to remember always. And if you are very methodical, then you probably will never miss the injury. And always remember the normal range of motion. Like as I told you, the dorsiflexor is 20, the plantar flexor is 40 to 50 degree, and the inversor is 20 degree, and inversor is 10 degree. And how to test the subtalar joint? The subtalar movement classically is around 5 to 10 degree. The muscle testing that I have not willingly given to, because 3 muscles that you have to remember that you can test. One is the tibialis anterior, that you have to test in the dorsiflexion. You can test the tibialis anterior. In the plantar flexion, you check the tibialis posterior. And when you evert the foot then you can test the peroneus. Sometimes if you test the peroneus, you can see there is subluxation of the peroneus on the peroneal group. That is also sometimes you can get to. So these are the few tests that you have to classically follow through. If I have forgotten any test, then probably I think John sir will elaborate if there is anything to miss on. Thank you for your kind and pleasant hearing.
Thank you very much, Swarnendu. Excellent as usual. I think you've covered everything more or less in terms of the examination. I'm sure if there are any questions, there'll be people asking them right now, and then we'll take it later.
Yes, sir, there are two questions in the chat box, sir. So one was asked while performing tenal sign whether ankle dorsiflex or not.
Janki, your voice is cracking. Can I check that in the chat box? Just I'm checking it. One
Yes,
is
sir. Sir, yeah.
while performing the tenal side, whether the ankle dorsiflex or not. No, it is not dorsiflex, it is not dorsiflex or plantar, it is neutral flexor. You just tap on like your median nerve. You can you remember one thing, you have to tap for 30 seconds along the course of the nerve. And if you dorsiflate, you can stretch the nerve more. But classically, it is not been described that you have to dorsiflate. It is a tapping for 30 seconds. Then you can ask the patient whether he is feeling any the tingling sensation or not. Then the second question is that anterior droid test and the talar test of the ATFL. Yes, anterior droid test is a very good question. Anterior droid test, during the video I have told you, it is like your anterior droid test of your the knee. There are, how you do it. The thing is that when you do the anterior droid test, the examiner will see how you are holding the leg and how you are holding your calcaneum. You have to stabilize the leg, then you hold the calcaneum like the cup. Then you do the anterior in neutral flexion. You just anteriorly glide your whole calcaneum, so that with the calcaneum, basically you are pushing the talus in front. So that then you have to do on the normal side. Then you check on the abnormal side. If there is any anterior movement which is abnormal or more than 5 millimeters, then you know that it is the anterior droitis is positive. And the second part of the question is the talar tilt test. The talar tilt test is basically the combination of three. We know the lateral side, you have to test three ligaments. One is the ATFL, the CFL, and the PTFL. So if you do, you have to do this talar tilt in three positions. One is the dorsiflexion, one is the neutral flexion, and one is the plantar flexion. When you dorsiflex, basically you stretch the posterior, so you do the PFL. When you neutral, then you do the CFL. When you plantar flex, then you do the talar tilt, you will test the ATFL. So the talar tilt, there are three components of it. In the anterior drawer, in neutral flexion, you basically anteriorly glide the talus, holding the calcaneum like a cup. Anything to add on, John sir?
No, that's fine. I think those are the basic tests. You can, if it's really unstable, you can actually almost sublux the joint, but that's not something that you'll do always. But
there is another one question. With please explain the this question was expected because the two tests. I will request all my juniors. The two tests probably will read and forget. One is the silver scale test. Another one is the Coleman block test. Silver scale test, before going to the test, you know that the gastrocnemius muscle origin is on the posterior condyles of the femur. So it is crossing the knee joint. So if you dorsiflex the knee, dorsiflex the ankle with the knee in extension. So suppose there is 20 degree of dorsiflexion in knee extension. Now you flex the knee. So now once you flex the knee, then the gastroc is relaxed. So suppose from 20 it is going to 30. That means there is increase in dorsiflexion. Then you know this is because of the gastroc tightness. So if the gastroc was tight, in flexion, the dorsiflexion was increased. So this is the theory. Once you understand, then you will understand the practical.
I think the real relevance of this test, especially in cerebral palsy patients, when you have to decide between releasing the TA or just the gastroc. Okay, so you can do just a gastroc lengthening, which is at the muscular tendinous junction, if the silver scale test shows you that the gastroc is only involved. Once the soleus is involved, then you have to lengthen the TA. Okay, so that is because if the dorsiflexion does not increase with flexion of the knee, that means the soleus is also involved. Okay.
Yes, because the test which is classically described for to understand whether the soleus is involved is the needle test. But how you do the needle test? Because this you are not going to push a needle in the soleus. So we have to identify by the silver scale test in the CP patient whether the only the gastrosoleus release, only the gastro release which correct the deformity, yes or no. So that is the basic of doing it. Remember one thing, as the gastroc is crossing the knee joint, is origin. So if you flex it, if there is no increase of the dorsiflexion, if there is increase, that means your gastroc is involved.
Gastroc is involved and the soleus is okay. That's what.
Soleus is okay. Yes, obviously this is because we have to identify whether the gastroc are which is the main component of your contracture of the backside.
Sure. Okay, great. Any more questions?
Sir, just one question, sir. What are the common cases of foot and ankle used to keep in the practical examination?
Yes, I think for the our colleagues, junior colleagues, that the cases that you have to read properly or you have to practice in when you do practice in your groups, like you commonly will get the CTEV or the congenital talliphasia equinovarus. You can get the post-op, they can ask you the what is the syndromic type that you can get. Then you can do the neglected one, then the relapsed one. What is the difference between it? Then you can get your planovalgus foot, or else you can get the hallux valgus with the hammer toe. So these are the common cases that we get during the exam. So CTEV, it is like the chronic osteomyelitis. If you answer any wrong question in the exam, you are in big trouble. In CTEV, if you answer any single wrong thing, you are in deep trouble. So CTEV, the planovalgus foot, the equinus foot, the chronic TA rupture also you can get, but sometimes you can miss it. These are common cases, and also you remember to get you can get the hallux valgus with hammer toe.
So I think if anyone have some other doubt, you can ask directly.
John sir, one thing just asked to because I knew you that John sir is like my guide for my orthopedic practice. So have I forgotten anything to mention during the exam? Anything to you can add on?
No, I think you've covered everything that is relevant to the exams. That's the important thing. I mean, that way you can go on forever for testing something or the other. But all the relevant things you've covered very well. Thank you. So I don't think so I mean, there are individual pathologies which will have other tests which you can't cover. If you try to cover all that, then it'll take all day to do that. So I think that's good.
Janki, from your side, what you know that you are also in the teaching thing. So anything to add on?
Everything you have covered, like just one thing, like in CTV, Pirani score and all should be on your tips that like a scoring of the club foods, those things. Usually the student used to read it, but it should be memorized.
Yes, that you have to memorize the Pirani scoring system. That is a very easy one because they will definitely, once you get and as I told you, if you can't answer a single question is like a chronic osteomyelitis case. So Pirani score, you have to memorize that Pirani score is a very easy score to remember. And all the Ponseti technique, the technique, how it is different than the classic one. John sir, we used to do the serial casting during our PG days. There is completely changed concept. So the Ponseti technique and the Pirani score, this you have to all understand and do. And they will also ask you when to start with the serial cast. What is what is the time period frame? when you do it, how you manipulate. These are all very questions, and the classic questions like the angles of the CTV that I have not covered because that is the radiological aspect, that is the theoretical aspect. Read everything about the CTV and you don't miss anything.
So it's important to also remember that the Pirani score is not a classification. Okay.
It is not a classification. It's just the.
It's a score that you do when you're doing the casting to see the progress of the casting and when it's okay to do the tenotomy. So it's not a classification of the type of clubfoot. This is something that people start thinking the Pirani score is a classification. It isn't.
It is a prognostic indicator. How you are succeeding, whether you are succeeding. It is a prognostic indicator.
So someone just asked about important things in CTV.
CTV case, what's important things, sir? Everything in CTV. Like I told you, probably the fourth time I'm telling you, you don't meet if you ask if you do anything wrong in the chronic osteomyelitis, is a big trouble in the Viva exam. It's like your CTV. Every single question. Suppose somebody can ask you what are the 4 deformities in the CTV that you find. What is even they can ask you all this. They will jump in the theory. But first thing is that don't miss anything about your finding, like your medial crease, the heel, small heel, the carved lateral side, smaller foot, everything they will ask to you. So from your look feel, like your CTV, you follow the dictum like look feel. So how it looks from the back side, heel will be smaller. There will crease will be there on the medial side, lateral side will be carved. So these are all everything is important. So CTV, I think it has to be a different class, both theory and practical. Otherwise, in a single class, it is very difficult to cover everything about the CTV.
Absolutely right. Okay, then thank you very much, Shamanto.
Thank you, sir.
Call it a day, and till next time, whenever I'm sure you'll be involved again in some future webinar. So till then, all the best and hopefully catch up again somewhere. Okay, bye.
Thank you, sir. Thank you, sir. Namaskar.
Thank you, sir.
Welcome.
Thank you very much,
Thank you,
sir.
Janki. Thank you, Janki. And thank you all the people, those who have joined, and the OrthoTV and the OREF. And my regards to John, sir, as always. Thank you, sir.
Sure. Thanks.
Thank you, sir.
Okay, bye.
Bye-bye. जानकी सब ठीक हुआ ठीक ठाक?
हाँ सर, काफी अच्छा हो गया सर। अभी एग्जाम भी है ना DNB का, तो वो काफी डाउट था फुट एंड एंकल में। आई थिंक ये सब कुछ कवर कर लिया है।
Because this is the, I think as we tried to only do the practical aspect, because
Yes,
this is the practical, because it is the, I think in practical this is the, we don't cover much of the foot and ankle. So they have to understand, at least 4 or 5 days they should not do any mistake, like whatever they had asked, like silver scale test, the thumb, the talus tilt test, the anterior drawer test, the subtalar movement. These are the very basic things. You have also asked you have also faced the same question during your exam too.
यस सर, ट्रू सर।
So
सर सब एक सर क्लास उसके लिए कि CP वाले बच्चों का एग्जामिनेशन, और जिसमें पोलियो वाला जैसे ओवर टेस्ट वगैरह, अगर उसका डिमॉन्स्ट्रेटिव वीडियो वगैरह कुछ होगा तो उसका करके कर लेंगे, क्योंकि वो डिफरेंट होता है जो जनरली
हाँ, वो
करते नहीं है।
करते नहीं है पोलियो का। मैंने जानबूझकर वो मसल टेस्टिंग वाला वो इसमें डाला नहीं।
नहीं सर, वो कभी ऐसा करेंगे सर कि हिप के एग्जामिनेशन में या फिर कहीं और का, जहाँ पे आप CP और उसका साथ में दिखा दें, मतलब न्यूरोलॉजिकल प्रॉब्लम का एग्जामिनेशन इस टाइप का कुछ करके,
हाँ,
उसमें स्पेसिफिकली जब जैसे जो CP का हिप का एग्जामिनेशन है सर, मसल का, डिफरेंट मसल का, उसमें सिविलर कर्व भी आ जाएगा, वो सब करके। तो न्यूरोलॉजिकल प्रॉब्लम वाला एग्जामिनेशन सर, वो एक
polio food is a very important topic that we have to
हाँ
definitely, because we have to we are not getting that many cases nowadays, But if we get
लेकिन
that,
अभी फिर भी अगर केसेस रहते हैं तो एग्जाम में रख लेते हैं सर।
अगर वो केस मिल जाएगा तो डेफिनेटली एग्जाम में रहेगा, तो 100% रहेगा.
हाँ
And we have to tell them in the group that they have to understand how to test the muscles and what are the basic principle of the muscle transfer and which muscle to
yes
transfer and what are the deformities and all this, and the classic test for it.
सो आई थिंक पोलियो को ही अगली बार एक बार प्लान करके सर
हाँ, पोलियो के ऊपर
पीपीआरपी
एक क्लास पोलियो और सीपी का हम लोग ले लेंगे ना, किसी जो
हाँ
एक्सपर्ट है पेडियाट्रिक से, हाउ टू एग्जामिन
हाँ
द पोलियो लेग एंड दिस थिंग, को जो पेडियाट्रिक करते हैं, तो उसको करेंगे तो अच्छा होगा. अच्छा होगा तो देन दिस पार्ट ऑफ द फुट एंड एंकल विल बी कंप्लीट, आई थिंक, फ्रॉम द स्टूडेंट साइड.
पोलियो के लिए मैंने किया था सर, तो उस समय उस्मान सर थे मैंगलोर में,
एक
उन्होंने
बार एक बार
पढ़ाया था।
एक बार फिर से करा
और अब
दीजिए,
तो वो है
फिर से करा दीजिए
सर।
सीपी और पोलियो का लोअर लिप का एग्जामिनेशन, तो अच्छा हो जाएगा.
हाँ वही सर। तो नहीं अब है नहीं सर वो, तो मुझे पता भी नहीं कि कौन,
नहीं नहीं नहीं,
इसीलिए
ठीक है.
पोलियो वाला एक प्लान करके कर लीजिएगा सर।
हाँ हाँ, पोलियो पोलियो और
पोलियो सीपी करके।
सीपी का एक बार हो जाए तो बहुत अच्छा होगा, क्योंकि इट विल
हाँ
बी इन कंटिन्यूटी देन.
यस सर, विल डू दैट। थैंक यू
ओके,
सर, थैंक यू
ठीक.
वेरी मच सर, ग्रेट सर।
अच्छा हुआ, ठीक है.
हाँ बहुत ही अच्छा हुआ सर।
थैंक यू, थैंक यू. ओके,
थैंक
सी,
यू सर।
बाय
बाय
बाय.
सर।
ये वीडियो हो गया, गाने गाने चावल किराना चला दी।